The Evergreen Media Network Studio, powered by Scott Tree Services.
Hi, welcome to the Preventus podcast, everybody, where we focus on all things health, wellness with a focus on prevention. I'm your host, Dr. Felice Hockey, with my co-host, or should I call you the host? Dr. Brett Hockey.
I'm the co-host today. It's good to be back.
You're the co-host today. That's
we're
right.
Rusty. We've been out of this.
Yeah, we're a little rusty. We had a bit of a sabbatical, so hopefully everyone will welcome us back with open arms. What did we do? Let's see. In our family, the end of May, mid-May to end of June is crazy. We have birthdays, anniversary. We usually take trips. We went to Europe, so we're back and we're ready to kind of go. Where we left off?
Well, I think we did cardio IQ or heart health. So we thought we would get through both of those with 2 episodes, but shockingly, we need a 3rd episode. So here we are, kind of to sort of tie up some loose ends with heart health.
Yeah.
But it's good to be back, and hopefully the audience can forgive us for some of the cobwebs that we'll have.
Yeah.
But we'll be ready to go.
Yeah, we'll get back into it. So, just to kind of recap a little bit, we were in our series, and I really encourage anyone who's just jumping in now and hearing this series, the 3rd part, I would highly suggest, kind of getting the foundational groundwork with part 1 and part 2 of our cardiovascular series. So basically what we were talking about is a test that we do in our clinic that assesses cardiovascular risk, and it's called Cardio IQ. And it's a test that Quest kind of partnered with Cleveland Heart Labs and developed, and it's really an awesome test, very well covered by insurance, and it takes a deeper dive into your cardiovascular risk, and you risk for essentially a heart attack, even strokes, etc. And so we went through different parts of the test, and there's kind of the standard cholesterol panel, which pretty much every person I've ever met over the age of 35 has had, which is your cholesterol, HDL, LDL, good cholesterol, bad cholesterol. Then there was the second part of the panel, which looks at particle sizes, and we went into that in part 1, and I think a little bit of part 2. Then the panel does go into something called lipoprotein little a, or apolipoproteins, which are little kind of markers that kind of clip onto LDL and make it stickier. Again, we went over this in part 1 and 2. And then the inflammatory panel, which, I don't think we took a deep enough dive. Where we left off last was we were talking about omega-3s, which is what the molecules you find in fish oil. And we were talking about some of their benefit. And then we kind of left off with, how are we going to apply this to our lives? It's really nice, all these numbers, and you kind of have to piece it all together. And it's sort of like risk factor bingo. But how does this actually apply to me? Like, how do I make a difference in my life once I see this panel, once I see the results and the numbers? So I don't know if you wanted to lead us off.
Yeah, let's kind of summarize, because even before we did the cardio IQ and the heart health, we talked at length about insulin resistance. And I think it's important to understand that insulin resistance is basically the body's or the cells within your organs an inappropriate response to the effects of insulin, okay? And when you're insulin resistant, you develop what's called oxidative damage basically everywhere. That means your body begins to rust. And as evidenced by this, 50% of everybody that gets diagnosed with type 2 diabetes, which is downstream from insulin resistance, already has what we call coronary artery disease. And so insulin resistance is highly, highly related to your cardiovascular health, and it's very possible to have, quote unquote, a normal cholesterol, or what we should say, conventional cholesterol panel, but actually be highly, highly inflamed. And the insulin resistance score, which is what we do as part of the cardio IQ lipid panel, and then all of the markers of inflammation, are essentially designed to pick some of those things up that we might be missing on a conventional cholesterol panel.
Yeah, so can I
Sure.
piggyback on that?
Yeah.
I call that kind of the iceberg effect. Your standard, and I think I said this already, so forgive me for those who have heard the other 2 series, but I tell my patients, think of this test like an iceberg, and you're used to the standard cholesterol panel, which is the tip of the iceberg. And that panel can completely be normal where you have actual underlying the deep part of the iceberg risk. And so this test really kind of uncovers that, would you say?
A million percent. And I think it's so important. We use this concept in our clinic called integration. It's so important to integrate. And as an example of that, when you look at a conventional lipid panel, we get two of the markers that we get are one marker is called the triglyceride. The other marker is called the high density lipoprotein, or HDL. When conventional medicine, when we diagnose metabolic syndrome, 2 of the 5 criteria for metabolic syndrome are a triglyceride of greater than 150 and an HDL less than 50 in women or less than 40 in men. So elevated triglyceride is one of the things that we can look at to figure out if someone's insulin resistant. However, if someone, just as an example, I had a patient today who had a triglyceride level of 120, but his insulin resistance score was perfect. So that person probably genetically has a predisposition to a higher triglyceride level, which in isolation, that 120 might make you think, uh-oh, the guy's maybe moving in the direction of insulin resistance. But all of his other mediators, his fasting glucose was 80, his A1C, hemoglobin A1C was 4.8, his ALT, which is a liver enzyme we look at, was normal. His fasting insulin was below 3. He's 25 years old. He's got 8% body fat. Someone else who has a triglyceride level of 120 and has all of those, a fasting glucose of 100, an ALT that's elevated, a fasting insulin that's elevated, we might say that person is definitely moving in the direction of metabolic syndrome and certainly has an element of insulin resistance. So it's important to integrate everything. So what we do is we look at the conventional lipid panel. We don't say it has 0 value. We look at that, but then we look at the cardio IQ lipid panel. And that's what we're going to start talking about today, is some of these different markers of inflammation and markers in the steps of active plaque buildup. And when we say plaque, we mean atherosclerotic plaque or vascular disease.
So if I can just summarize what you're saying as best I can, you're saying that you can't just look at one piece. It's sort of like giving someone one piece to a 100-piece puzzle. You're never going to complete the picture that way. You have to look at the entire thing.
We should be looking at, in clinical medicine, we should be looking at cardiovascular risk. We should be looking at conventional lipid panels, cardio IQ lipid panels. We should be measuring insulin resistance, targeting, reversing it. We should be looking at liver health. So that includes looking at liver enzymes. We should be looking for protein in the urine. We should be talking to the patient about signs and symptoms of endothelial dysfunction, which typically in women manifests a lot of times as sexual dysfunction, in men manifests as erectile dysfunction. So we should be integrating all these things together and then coming up with a comprehensive analysis, game plan, if you will, for health optimization, prevention, functionality, and hopefully that translates into longevity and health span, high quality of life as we age.
And just to say, you can't just look at somebody. You can't look in the mirror and say, oh, I'm healthy, like I'm thin. You have those who are thin, who are metabolically unhealthy. We call them TOFIs, thin on the outside, fat on the inside. It's not a silly term. It's an actual term that we use in medicine. And then there's actually metabolically healthy obese. There are people who are obese who are metabolically healthy. So, to complete the picture, you can't just point at someone and say, that guy's fine, because everybody knows somebody who was a marathon runner who was really fit, who, unfortunately passed from a heart attack, a massive heart attack. So that's also part of the thing. It's not just kind of looking at somebody and making an assumption like, oh, he's unhealthy. You really don't know until you take deeper dives with labs. So with that being said, let's talk a little bit, if we can, about the inflammatory part of the panel. And there's usually 6 inflammatory markers tested. And I think you kind of already alluded to this, but why do we care about inflammation?
Well, generally speaking, to understand, the number one killer of both men and women in the United States and in the world is what we call coronary heart disease or coronary artery disease. And oftentimes it's a silent killer. I forget the stats, but I think it's well over 50% the first time someone's going to manifest with coronary artery disease is if they're having acute coronary syndrome. I remember
Yes, it is.
I don't remember exactly what the stats are. And vascular disease is a function or a product of really a couple of different things. Father time, which we can't really address, you can't slow down time, so that's probably your biggest risk factor. But after that, it's a function of what we call your apolipoprotein B particle burden in combination with inflammation, oxidative damage, and vascular immune dysfunction, okay? And so the Cardio IQ lipid panel is designed to, number one, look at your ApoB particle burden, but it's also designed to look at markers of inflammation, markers of oxidative damage, and markers of vascular endothelial immune dysfunction with the goal of reducing those. And you know, there's a lot to be said about statin drugs. I think that you hear a lot of people talking about, you know, they should be in the drinking water, and then you'll see some things on the internet where people are saying that they're horrible and they cause all kinds of problems. I think that the story is much more nuanced than just these broad spectrum claims. And I think that it's important to understand that cholesterol biochemistry and physiology is extremely complex. And, you know, the Cardio IQ lipid panel hopefully allows us a little more nuance into targeted therapies to do all of those things: lower the ApoB burden, lower the levels of oxidative damage, inflammation, and vascular immune dysfunction.
Yeah, you know, it makes me think of this study that was done. I don't know if it was so much of a study or just kind of like an observation where they had these twins. I don't know if I ever told you about this, these females, and I want to say they were in their 60s. And they juxtaposed the pictures. You can honestly like Google this and look this up. And they look decades apart, and they're twins, identical twins. And the one twin lived a very healthy lifestyle, worked out pretty much every day, ate really healthy, didn't smoke, didn't really drink a lot, you know, prioritized sleep. The other one did not. And the difference in the age that they look is incredible.
One was a smoker and one was not.
Yeah, one was a smoker, a drinker, drugs, the whole hard life.
That's a great segue. That's a great segue. And I know you wanted to talk about some of the different markers of inflammation.
Yeah.
But the first thing on our panel is something called the highly sensitive CRP. And so CRP stands for C-reactive protein. And what C-reactive protein is it's a molecule that is created or produced in your liver in response to what's called tumor necrosis factor alpha and interleukin 6 being delivered to the liver. The liver sees these two, what are called pro-inflammatory mediators, and it converts interleukin 6 and tumor necrosis factor alpha into highly sensitive CRP. Why is interleukin 6 and tumor necrosis factor alpha important? Well, those are two big markers of an inflammatory cascade. And to your point about the twins, I have several patients in my practice who the rest of their Cardio IQ lipid panel looks fine. Their lipids actually look fine. They're not insulin resistant. However, they're smokers. And the upper limit of normal for us on our panels for highly sensitive CRP is 1. 1 to 3 is sort of an intermediately elevated level, and then above 3 is significantly elevated. Well, I can think of several patients offhand who are smokers, and their highly sensitive CRP is 10.
Yeah.
And so you can see how, if nothing else, if you are a smoker, how deleterious that is to your vasculature and how you are rapidly accelerating the development of atherosclerotic plaque in your body. And so the number one thing that you can do to offset risk as far as vascular disease is concerned is to stop smoking. The number two thing after that is to develop strategies to make sure that your body is as insulin sensitive as possible. And that gets a little more complex, but just to illustrate the point of how, you know, bad these lifestyle and specifically smoking, that will manifest as significantly elevated on our Cardio IQ lipid panel with a highly elevated, highly sensitive CRP. So that's the first thing. And
it's also a non-specific marker. I tell patients who are really healthy, who do a lot of things right, you could have like a sinus infection that'll be elevated. So it's not always pointing to the cardiovascular risk, but the other 5 in the panel are a little more cardiovascular oriented, wouldn't you say?
You got it. The next thing that we look at is something called, it's something called an LP-PLA2. And basically, the LPPLA2, I'm going to nerd out a little bit, but it runs with an oxidized LDL, okay, an LDL particle. And it's an enzyme that when it fuses with the oxidized LDL, it makes an oxidized fatty acid, which in and of itself is deleterious to the vasculature, and then something called lysophosphatidylcholine. And lysophosphatidylcholine is an interesting, lysopc, it's an interesting little molecule. It moves to the endothelial cell. It causes endothelial cell dysfunction, which we'll talk about here in a little bit. It traps monocytes in the endothelial cell, which we'll talk about a little more when we talk about the oxidized LDL. And then it induces endothelial cell death. We call that apoptosis. And so
when you say endothelial cells, you're talking about the cells that line the artery.
So let's the cells that line the vasculature. These are endothelial cells. So one of the things that can happen when you have endothelial cell dysfunction is the cell doesn't respond appropriately to the effects of insulin. And when that happens, due to a variety of reasons, and one of them is because of this lysophosphatidylcholine, the cell can't effectively bring glucose into the cell, and one of the main jobs of the endothelial cell is to make nitric oxide. Nitric oxide is important for a whole slew of different reasons, but the two biggest reasons are it's a free oxygen radical scavenger. So it's basically cleans up all these bad things along your cell wall, along the endothelial cell wall, but then it also is responsible for getting the vessels to dilate. So it's very important for blood pressure, and it's also important for sexual function in men. So if I see a guy and they're complaining of erectile dysfunction, one of the things that I look for is an elevated LPPLA2. The other thing that's important with that is that if someone is complaining of erectile dysfunction, a lot of times that's a canary in the coal mine that you've got cardiovascular problems. And cardiovascular disease, vascular disease in general, is downstream from erectile dysfunction.
Okay. And so do you go right into ADMA right there, since you're talking about nitric oxide, or is it better to go to the next one in line?
Yeah, I think that's a great segue. So ADMA and then SDMA. So asymmetric dimethylarginine and then symmetric dimethylarginine. These are two enzymes that compete with nitric oxide for arginine, okay? So the bottom line, what it means when those two enzymes are elevated, when they're elevated, a lot of times patients have difficulty making nitric oxide. So if they're inversely proportional, we say, to nitric oxide. So if they're high, a lot of times your nitric oxide is low. And then you have to then develop strategies to upregulate nitric oxide in your body. Number one, a lot of times you'll see ADMA and SDMA are elevated with a poor diet, with insulin resistance, and also with smoking.
And what happens when there's an issue with their nitric oxide? They don't dilate their vessels as well?
That's exactly like we said, vessel dilation, vascular dilation, and then free oxygen radical scavenging. So we talked about the oxidative damage. Nitric oxide is a free oxygen radical scavenger. It's an antioxidant. So it's very important for maintaining vascular health and avoiding that cascade that where you develop atherosclerotic vascular plaque over the long term.
Yeah, so if we're using your analogy, it's essentially preventing the rusting.
Correct.
Yes.
Absolutely.
And then there's two more on the inflammatory panel. There's right? Yeah, oxidized LDL.
We got oxidized LDL. We got myeloperoxidase. So we hit on oxidized LDL a little bit. So just to kind of summarize, the very first step in the development of atherosclerotic plaque is the development of foam cells, okay? And the very first step is that the LDL particle, or the ApoB containing particle, moves into the vessel wall and becomes oxidized. It's important to understand that if the ApoB particle, if the LDL doesn't become oxidized, you do not develop vascular disease. However, when it becomes oxidized, a couple things happen that sends out cell receptors or cell signalers called selectin and VCAM, and they move to the outside of the cell. They attract monocytes. The monocytes attach to those cell receptors. They move into the cell, and when they move into the smooth muscle cell, they become macrophages. When the macrophage engulfs the oxidized LDL, they form foam cells. And so,
which are fatty cells,
which are fatty cells, which are the very first step in the beginning of atherosclerotic plaque. So the very first step that happens is your LDL becomes oxidized. So we measure your levels of oxidized LDL in plasma, and we make the assumption that this is reflective of the oxidized LDL that's also in your smooth muscle cell. And so the goal is that if you do have elevated, if your oxidized LDL is elevated, we need to get your ApoB, your LDL down, and we need to get your levels of oxidative damage and inflammation down.
Okay, and what's really remarkable, and you're talking about monocytes and all of these things, it's really not just having elevated LDLs. A lot of patients will get scared when they see that, but it's more so kind of the process surrounding it, the oxidation, et cetera, the inflammatory process, the breaking down of the endothelial wall or the artery wall.
1,000,000%. And just to illustrate the point, I mean, like we talked about before, I would rather have a patient with an LDL of 140,
which is
and
high,
virtually no levels of inflammation, no markers of inflammation, no oxidative damage as reflected on the cardio IQ lipid panel. I would rather have that patient than a patient that has a normal cholesterol panel and has a highly sensitive CRP of 10 because they smoke like chimneys. And just to kind of demonstrate the fact that we need to integrate all this data together and form a picture in our mind based on the mechanism of action behind the development of the plaque.
Okay, and then the last one on the inflammatory panel, myeloperoxidase.
Myeloperoxidase is a tricky one. It's released by neutrophils. It's an enzyme that's released by neutrophils in response to invading organisms or infection or oxidative damage. And then myeloperoxidase binds with what's called peroxide, so that's called H2O2, to give you what's called hypochlorous acid and nitro or oxidized nitric oxide. Okay. What's important about the oxidized nitric oxide is it will then form what's called nitrotyrosine. Nitrotyrosine is seen in large numbers in atherosclerotic plaque in the aorta and lots of other big vessels. So myeloperoxidase is essentially upstream from nitrotyrosine. Nitrotyrosine is a big player when it comes to the atherosclerotic vascular plaque in the big vessels, aorta, carotid arteries, etc. And so if we see that myeloperoxidase being elevated, we need to hone in and start developing strategies to minimize that inflammatory cascade.
Yeah, and it's not just cardiovascular disease with myeloperoxidase. I mean, there could be an infectious process going on.
Just like highly sensitive CRP.
Exactly.
Yep,
so it's one of those that you kind of have to investigate more. You have to monitor, et cetera, if it's elevated. And when you go back to neutrophils, that's essentially one of the cell lines involved in our immunity. And again, just pointing to the fact that the cardiovascular disease process, the building of plaque, is really our own body trying to protect itself. It's the immune system rushing to the site of injury and saying, let's fix this. And ultimately, it leads to this problem, this patch, which is a plaque.
Right.
Okay, so I know we're kind of, short for time a little bit. So I just wanted to talk a little bit about just treatment strategies. We've talked about statins in the prior podcast. We talked about PCSK9 inhibitors. We talked about omega-3s. We have probably exhausted the index on lifestyle measures, exercising, weight training, watching your carbs and your sugars, staying away from processed foods. If you had to surmise something, that you think is really important, or, even a supplement that you're like, this is worthwhile, what would you say? Yeah,
I mean, such a good question. Really difficult to summarize. I think it gets back to our core principles at our clinic, and that's diet. So low insulin recruiting, low inflammation diet, rich in leafy greens, lean chicken, fish, omega-3s, omega-9s, avoid high fructose corn syrup, sugar, processed food. So diet, evidence-based resistance training regimen that's sustainable, and that's key. Everybody's different. Everybody's got different athletic backgrounds, so an evidence-based resistance training regimen that's sustainable, and then optimizing your sleep and mitigating your stress. So that would be the core foundation, and then I think it's a matter of nuance. So just as an example, some people respond very well to statin drugs. It's important also to understand that statin drugs can actually increase your LP little a. So they do a great job of lowering your LDL or your ApoB your other three ApoB, but they can increase LP(a). So that's why it's so important to have an integrated picture, a comprehensive picture, so that you can make the right choice when reaching for the anti-cholesterol medications. So I would just leave it at that for right now, and then diet, exercise, sleep, stress, and then hormonal balance and optimization.
Yep.
I think that would form the three pillars.
Which I'm proud to say we're doing, I feel like, a pretty good job at our office, kind of diving into all of that. So if you subscribe to our channel, the Preventus podcast on YouTube, and you think of other things you want us to talk about from a cardiovascular standpoint, please, post it underneath in the comments section. And because right now we're just going to end this series for now. We're going to leave it there.
I mean, just to get 3 episodes is like,
it is very difficult.
A lot. We could talk about this for 10 episodes.
But thank you so much for tuning in and listening.
Thank you.